All right, so the final part of the three processes is tubular secretion or tubular excretion. You're secreting stuff back into the tube so that it is excreted by the body. So saying it either way is fine. The tubules secrete ions into the lumen to be excreted in the urine because what leaves that last tubule goes directly into the collecting duct, and then that's going to leave. It's going to go through the pyramid, into the calyx, into the renal pelvis, the ureter, the bladder, the urethra, and the toilet. Okay? Tubular secretion of potassium and, okay, whenever you see just a normal H ion, a hydrogen ion, that's another way to abbreviate the term free acid. Okay? So tubular secretion of potassium and free acids help to regulate potassium levels and also regulate our acid-base balance. Of course, I'm sure you remember, or at least lie to me and tell me that you do, that the metabolic process, I don't care if you're metabolizing, sugar, whatever, you're making acids in the process of that metabolism. Well, obviously, you're making more acids than your body needs. So we need to excrete those excess acids. That's one of the reasons why our urine pH is anywhere from 5 to 7, because the urine is going to excrete those excess acids. Now, it's also handy because acidic urine does not breed bacteria. So, it's kind of a great thing that we do, and then it's got a great side effect as well. The kidney will regulate acids in conjunction with buffers in the blood, and then also kind of doing a little teamwork with the lungs. The lungs are very reactionary to acid-base balances, but they're very fast. They'll wait until there's a problem and then they'll react, but when they react, they're very fast at getting it to fix itself. The kidneys are a little more methodical, so they're a little slower, but the kidneys can also attempt to prevent acid-base problems. So, they have to kind of work together to make this all reach homeostasis. So the end product of glomerular filtration and tubular reabsorption and secretion is urine. Urine is composed of water, sodium, potassium. Hey, does this list look familiar? Did we see this list in the beginning? Yeah, because it's the same stuff. What has changed? The amounts and the concentrations. Okay? Clearly we've reabsorbed some of that, but still there's going to be some of it leaving with every bit of urine. The body excretes 1 to 2 liters of urine, which is about 1% of actually what is filtered per day. Now, also, understand that the kidneys are like Santa Claus. They know when you're sleeping and they know when you're awake. So you don't get the same level of filtration when you're sleeping as when you are awake. Well, that's actually a really smart innovation, because if you filtered as rapidly and as well during your sleep as you did during the day, you would wake up at least once or twice during the night minimum and have to empty your bladder because you would be constantly making tons of urine. So on your waking hours, you're going to have a higher GFR, glomerular filtration rate, than your sleeping hours, okay? So it's not all laid out in a perfect 24 hours. But on average, we excrete about 2 liters of urine per day, and that is only about 1% of what is actually filtered when you think about how many times we filter all of that blood going through the kidneys, every 5 minutes. Glucose normally should be reabsorbed in the tubule. If it happens to pass into the tubule, if it gets past the glomerulus and gets in the tubule, it should be reabsorbed. It should not normally be found in urine. When it's not reabsorbed is when your patient is already hyperglycemic, and the kidney is using that as a method to try to excrete glucose. It's not a good method to excrete glucose because it can cause glomerular and nephron damage. But your kidney is trying for homeostasis. So if that patient's constantly hyperglycemic, they're going to excrete glucose in their urine. So not only will you test it and find it, that glucose, that constant excretion of glucose in the urine, is the first step in the destruction of the kidneys by the wonderful disease, diabetes. Okay, so finally we have made urine. We actually have some. What do we do with it? Well, those peristaltic waves will move the urine. Obviously, it came from the collecting duct, it emptied into those pyramids, which emptied into the calyx and into the renal pelvis. Then peristaltic waves move that urine from the renal pelvis down through the ureter. When anywhere from 200 to 400 cc's of urine is collected in the bladder, that first, "Hey, I gotta pee" message is going to be sent to your brain. Now, of course, you can obey it and go, "Oh, geez, yeah, I gotta go pee," or you can ignore it. Like I kind of opened the lecture, the very first video with that analogy of the nurse's bladder, and how sometimes we keep prioritizing, and us going to the bathroom goes lower and lower. But that's not really good for the bladder, because you're getting those messages sending to your brain, you're not obeying them. Eventually the bladder may distend and hold several times that amount. Just because it can doesn't mean it should. And there will come a point where we have a saying that urination is both voluntary and involuntary. When your brain has decided that you are too stupid to manage your urine, your micturition or voiding habits, then your internal and external sphincters will simply relax, whether you like it or not, and you will void. That is, something that you see on patients who do this, a whole lot for other reasons. But also, if you've got a somewhat full bladder, and then you have something that kind of just puts you over the edge, and you're too far away from a bathroom and you can't make it there, it doesn't matter if you're an adult or a kid, you're not going to be able to hold your urine. So urination is voluntary until the point that your body takes over and it becomes involuntary. We're going to talk for just a minute about some other regulation and excretion things. One thing that you need to understand, and we talked about this briefly in homeostasis, but calcium and phosphate have a reciprocal relationship, and they're highly tied to the renal system for their regulation. Parathormone is a hormone that is produced by the parathyroid gland, which is in endocrine. You'll get to it later. But that parathormone's job is to help maintain serum calcium levels, where you're thinking, what's that have to do with the kidneys? When calcium levels are low, parathormone is secreted, but it not only pulls calcium from the bone, it actually acts on the renal tubules to promote the reabsorption of calcium, okay? Also the excretion of phosphate. But what that can mean is, if your calcium levels are chronically low, first of all, you're going to be pulling calcium from your bone, but it's also going to get the renal tubules to try to reabsorb calcium, because normally we should be excreting calcium in our urine. And in fact, we want to make sure that we're keeping it very dilute, because calcium, when given a chance to precipitate out of urine, can be one of the mineral bone salts that become a urine stone salt. So it could be calcium or magnesium oxalate. There's a bunch of other things that it can be, but calcium is obviously right up there on top of the list. Another type of regulation that I mentioned at the beginning of the lecture was the blood pressure regulation. Blood pressure regulation in the kidney is maintained in two ways. First, by altering our fluid volume maintenance. What that means is acting on the kidney in a way to retain or eliminate fluid, retaining it or hanging on to it, or eliminating it or excreting it. And then also by release of the enzyme renin. Renin is released by the kidney in response to a low blood pressure in the renal artery. You've got sensors in renal arteries and the glomeruli that kind of give feedback to the body that says, hey, we are having a drop off in our blood pressure, okay? If that happens, that renin is going to be excreted. So hopefully this next part sounds a little familiar to you, but renin acts on angiotensinogen. Angiotensinogen is a precursor that is then converted to angiotensin 1. Angiotensin 1 then is acted upon by another enzyme in the lungs, which I'm not going to make you learn the name of, which converts it to angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor. So think about that. If your blood pressure is low and suddenly you're given something that causes you to constrict your vessels, what's that going to do to your blood pressure? Hopefully you answered raise it. Angiotensin 2 then also stimulates the release of aldosterone from the adrenal cortex. I just spoke about aldosterone a couple of slides ago. Aldosterone acts on the tubules by increasing sodium reabsorption, which in turn increases water reabsorption. So basically, angiotensin 2 acts in two ways. It's a powerful vasoconstrictor, and it initiates a process which increases your fluid retention. So between the two, constricting the vessels and increasing your volume, what is blood pressure but cardiac output times peripheral vascular resistance? So if I increase my peripheral vascular resistance by vasoconstricting, and I increase my cardiac output by increasing the volume of fluid, I am going to increase the overall blood pressure. All right, the final function that we're going to discuss is stimulation of red blood cells. The kidney excretes erythropoietin. It's oftentimes abbreviated EPO. This is a hormone. This hormone will be excreted in response to low oxygen levels in renal arterial blood. So you remember those sensors I told you that were in the renal arteries and then also kind of sitting in the glomeruli? Those sensors are what give us the feedback that says, hey, our overall oxygenation level is lower. That releases EPO. EPO then stimulates the bone marrow to start to produce new red blood cells. If you remember, stem cells can grow up to be red blood cells, white blood cells, or platelets, okay? This EPO will encourage those stem cells to kind of mature and grow up to be red blood cells because we need them for oxygenation. Okay, we're going to round out this part of the lecture by just talking about the age-related changes that occur in the renal system. Basically, any age-related changes that are going to happen only affect the kidney or the bladder. They really don't have much effect on the urethra itself or on the ureters or anything else that's kind of extraneous. It's pretty much just kidney and bladder. So let's start with the kidney. As you get older, you will lose nephrons. Sometimes nephrons get damaged. Maybe you had a strep infection that didn't get taken care of right away, but whatever the cause of it, you are going to lose nephrons over time. Hopefully, you lose them in a small enough amount that it's not hugely impactful. Another thing that will happen is the membranes in that nephron, not only in the glomerulus itself, but also along the nephron, will thicken. Those membranes, when they're more thickened, it makes it more difficult for fluid to pass through, for reabsorption to occur, and for secretion to occur. Then you also can get sclerosis of renal blood vessels. So as a result, your glomerular filtration rate and your renal perfusion decline. What we mean by sclerosis is they start losing their elasticity. So when you start losing your elasticity, you can't have that high level of ultrafiltration performed all the way down to the nephron level. Then renin levels and aldosterone levels will also decrease, so your renin-angiotensin system will be less responsive, and your aldosterone, that ability to reabsorb sodium, will be impaired. Tubules are also less responsive to ADH, so there was our other way to retain fluid. Why do you think so many times our germ population ends up being dehydrated? Because all of the things that we put in place, they don't drink a lot of fluids to begin with, but all of the things that are put in place to help them not become dehydrated are declining. These things that the kidney are supposed to be doing begin to decline as people age. It also has a decreased ability to dilute or concentrate urine and decreased ability to adapt to stress. All right, so that was the kidney. Now let's talk about the bladder. Age-related changes in the bladder usually deal with the bladder muscles weakening or the connective tissue around the bladder increasing, which causes decreased capacity and incomplete emptying of the bladder. Because of that, your chance for urine reflux also increases, because if your bladder is more full when you're trying to void, you have an increased risk of urine kind of leaking back up into the ureteral orifices. Incontinence, now this is like a, I guess I would call this a soapbox issue for me, so tread carefully, because I really, really get sick and tired of people saying that incontinence is normal, okay? Incontinence is common. It is a common problem of our older adult population, but there is nothing about incontinence that is normal, okay? Let's not treat it like it's normal so that we shouldn't expect to be continent, because that's not true. Females often have incontinence issues related to, multiple childbirth and possibly either low estrogen levels or exceedingly high estrogen levels when they don't have any progesterone to back it up, because both of those issues can make estrogen not perform appropriately. And then males often have issues related to obstruction, especially obstruction caused by the prostate. But regardless, one of the biggest, I'd say, increasing areas of research in urology at present is all about what we call urodynamics. Urodynamics is the study of voiding and incontinence and using all of the different ways that we have at our disposal to, either correct the incontinence, do a surgical correction, a medication that can help correct it, but whatever. We are going to try to, cure or at least treat their incontinence so they have far more continent days than they have incontinent days. So finishing off with our assessment, every unit we always talk about kind of like a focused assessment where we, look at specific problems related to that body system. For the renal system, we're going to spend a good amount of time getting a very detailed health history from our patient, because we want to know, why are they there? Let's face it, people do not come to urologists for fun. This is like not a good time, a pleasant visit. So they're coming up to us. They've got probably an issue that is pretty major that they've been dealing with for quite a long time because they didn't want to come to the doctor about it. So by the time they get to us, it's probably a pretty significant problem. So we want to get their chief complaint, but we also want to know their medical and surgical history, because sometimes their surgical history or some of the medications that they're taking will sometimes explain their renal or urologic issues. We also want to find out if they've got a family history of urologic problems, because there are a significant number of urologic issues that are familial, meaning you will see them pop up more in a particular family group than they would statistically just on average. And then you want to get their own individualized urinary function history. Do they have now, or have they ever had dysuria, polyuria, frequency, nocturia, hematuria, anything that you can think of there that's going to give you some good background information. We want to collect that data. Then we start the objective part of the assessment. So we would inspect their skin. We're going to learn later on what this would actually mean, but we look on their skin for evidence of like crystals or something that looks kind of, scratchy and crystalline. Especially look in the folds of their skin for that. We're going to look for dehydration or edema, because we can have either problem with the renal system. We're going to, monitor their respiratory rate, because remember, they can change their respiratory rate based on other physiologic things that are going on, to include maybe a kidney infection or metabolic acidosis, which is kind of a kidney problem. And clearly, if your patient's hypervolemic and they've shunted some fluid into their lungs, that can also cause their respiratory rate to go up. We're going to check their abdomen for scars. A lot of times people, they don't always tell you every single surgery that they've had, because sometimes they just forget. If you need to, you can palpate the bladder for distension or tenderness. These days, with the bladder scanners being pretty prevalent, we have a lot of opportunities to use that as a better measurement tool than just palpation. And then we can auscultate right over the kidney and listen for renal bruits. Renal bruit would be that swishing kind of sound, and you would hear it right over the kidney. Very rare, but it is one of the things that we assess for. And we may need to percuss. When you percuss over the kidneys, the way you do it is you literally I use my non-dominant hand, and I lay my non-dominant hand flat against their back, right over where the kidney would be. And then I make a fist out of my other hand, and I kind of use it like a hammer fist. I just lightly pound on my own hand, but that feeling, that kind of little shock wave goes through your hand and into their body right about where the kidney would be. If they have a stone in there or any other irritation in there and you do that, that will be enough stimulation to activate, the nerves in that area, and they will, complain of pain. And then kind of last is inspection of genitalia. We don't do this a lot with females so much because females have a gynecologist. Females, most of the time, go see an OBGYN doctor if, that area needs any kind of attention or whatever. It's, we've got a problem, they have an infection. That's usually who they're going to see to have that treated. But males do not have that. So males end up seeing their urologist. Urology is the study of the male and female urologic system and the male reproductive system. So you're going to see some overlap on both of those, okay? So around the penis, first of all, we're going to note if it's circumcised or uncircumcised. Look for lesions, scars, or any kind of discharge. A lot of times, urinary tract infections and, STIs, they're not very pronounced. So it might just be a small amount of discharge that's coming out of the penis, and the patient tells you, well, I've had that for quite a while, but it's still an underlying infection that needs to be taken care of. When you're assessing the scrotum, both testicles should be descended, approximately equal in size. A large difference between the two, or an inability to palpate two distinct testicles, may be indicative of a hydrocele or some other problem. And while not technically a renal problem, they can impact the renal system if they get big enough. But again, we also kind of look at that because it's the reproductive system. And obviously, folks, if you're doing any of this inspection of genitalia, we need to make sure we are wearing the proper PPE.